Hello everyone. In this class, we'll study about the cardiac output. The learning objective of this class would be to define cardiac output, stroke volume, and diastolic volume, and systolic volume, ejection fraction, cardiac index, and cardiac reserve, and give their normal values. Appreciate the variation in cardiac output in different physiological conditions. List the method of measurement of cardiac output and learn the principle of measurement of common methods. Cardiac output is defined as the amount of blood ejected by each ventricle per minute. Hence, cardiac output can be given as stroke volume into heart rate. The normal cardiac output in adult is around 5 to 6 liters per minute. It will be approximately 8% of the total body weight. Stroke volume is the volume of blood ejected by each ventricle with each beat. Normal stroke volume is about 70 ml. Cardiac index is the cardiac output per square meter of body surface area, and hence cardiac index can be given as cardiac output at rest divided by body surface area in meter square. The normal average cardiac index is 3.2 liter, and the body surface area calculated by using Du Bois formula. The body size varies greatly in the same age and gender, and cardiac output is influenced considerably by the body size. The effect of age on cardiac index rises rapidly to a level greater than 4 liters per minute per meter square at the age of 8 to 10 years, but then it declines steadily about 2.4 liter per minute per meter square at the age of 70 years. The decrease in cardiac index could be due to decrease in activity and declining muscle mass with the age. End diastolic volume is the volume of blood remaining in the ventricle at the end of diastole. Normally it is around 130 ml. Ejection fraction is a percentage of end diastolic volume ejected with each beat. This can be given as ejection fraction is equal to stroke volume divided by end diastolic volume into 100. Normally it is around 65%. Ejection fraction is a good index of myocardial performance. And systolic volume is a volume of blood remaining in the each ventricle at the end of diastole. It is around 50 ml. Cardiac reserve is amount of blood that can be pumped by each ventricle in excess of normal cardiac output. Normally it is around 15 to 25 liters per minute in non-athletes and 20 to 40 liters per minute in trained. Physiological condition that affects the cardiac output. There can be conditions which can increase the cardiac output. They are exercise, anxiety, emotion and excitement, increased environmental temperature after eating, pregnancy. And some of the conditions that can decrease cardiac output are standing from lying down posture, excessive sweating can decrease the cardiac output. Conditions that do not change the cardiac output are sleep, mild to moderate change in the environmental temperature. Cardiac output is less in elderly, in which is due to the decreased heart rate and stroke volume. In children, though the heart rate is more, cardiac output is less due to the less stroke volume. The cardiac output is about 10% less in case of females. Cardiac output increases in exercise due to the sympathetic stimulation. Cardiac output increases due to the increased heart rate and stroke volume. Tachycardia and increased stroke volume occur due to increased discharge of non-adrenergic sympathetic nerves to the heart. Sympathetic activity increases by psychic stimuli and stimulation of receptors in the muscles, joints, and tendons. Inhibition of vagal tone also contributes to tachycardia. This is the diagram showing how cardiac index it increases during the 10 and 12 years, then it gradually decreases as the age advances. And stroke volume increases due to the increased myocardial contractility by sympathetic stimulation and also due to increased venous return. Venous return increases due to the sympathetic vasoconstriction Venoconstriction and increased skeletal muscle pump activity. Increased thoracic pump and mobilization of blood from splanchnic and cutaneous beds also contribute to the increased venous return. The cardiac output increases in emotional excitements due to the sympathetic stimulation. And cardiac output increases after eating due to the increased metabolism. The cardiac output increases in pregnancy due to increase in blood volume. That mainly occurs due to the expansion of the extracellular fluid volume. The major hemodynamic change in the pregnancy is the increase in the cardiac output. The cardiac output starts increasing in early phase of pregnancy and is significantly high by the end of first trimester. The increase in cardiac output reaches its maximum to about 40% increase in mid-pregnancy and then remains elevated at that level till term. The increase in cardiac output is due to increase in the both stroke volume and heart rate. Increase in stroke volume is mainly due to increased end diastolic volume, which occurs due to increased venous return as a consequence of increased blood volume. Heart rate increases by about 10 to 15%, reaching its peak at term. Assuming standing posture from lying position decreases the cardiac output due to the accumulation of the blood in veins of lower extremities caused by the effect of gravity. About 200 to 500 ml of blood is immediately pulled in the capacitance vessels of the lower extremities. This decreases the venous return and results in decreased cardiac output. This is cause of immediate fall in blood pressure on standing. Prolonged standing can cause fainting in sensitive individuals. The effect of change in a posture are more marked if it is done passively with the help of tilting table, as muscular activity of the act of standing is absent in passive tilt. The muscle activity after assuming the posture is also lower in passive tilting, and the effect of muscle heart reflex is eliminated. Increase in the environmental temperature increases the cardiac output by two mechanisms by activating the sympathetic system and by increasing the body temperatures. Decreased temperature has the opposite effect. However, mild to moderate change in the temperature does not affect the cardiac output. Cardiac output changes only in extreme temperatures. Coming to measurement of cardiac output. Cardiac output can be measured by direct or indirect methods. Direct methods. Cardiac output can be measured directly by placing an electromagnetic flow meter in the ascending aorta or by using cardiometer. These are accurate methods of measuring cardiac output. However, these direct methods are applicable only in experimental animals or in humans undergoing open thoracic surgery. In human, cardiac output is usually determined by using Doppler combined with echocardiography. Some of the indirect methods of measurement of cardiac output are fixed method, indicator dilution method, thermodilution method, ballistocardiography, echocardiography, X-ray method, and pulse pressure method. Fixed method. Fick principle is defined as the amount of substance taken up by any organ or by whole body per unit time is equal to the arteriovenous difference of substance times blood flow. The procedure is cardiac output can be measured by measuring the amount of oxygen consumed by body in a given period and dividing this value by arteriovenous difference of oxygen across the lungs. The oxygen consumption of the body is measured by spirometry. As the arterial oxygen content is the same in all the parts of the body, for measuring oxygen content of the arterial blood, the blood is obtained from any peripheral artery. The venous blood is collected from the pulmonary artery by placing a catheter into it through the heart. Then cardiac output can be calculated as the cardiac output from the left ventricle is equal to oxygen consumption in ml per minute divided by arteriovenous difference of the oxygen. Advantage of this method is this is accurate. No chemical is injected into the body. Some of the disadvantages Disadvantages are the catheterization should be done by expert hand. Hospitalization is required for catheterization, and patient may be apprehensive of catheterization that increases the cardiac output. Simultaneous measurement of oxygen consumption makes the process difficult. It is difficult to measure cardiac output by this method in ambulatory patient and during exercise. Second one is indicator dilution method. Principle here is a known amount of indicator is injected into the circulation, usually through arm vein, and the concentration of the indicator is measured in serial samples of arterial blood. The output of the heart is equal to the amount of indicator injected divided by its average concentration in the arterial blood after a single circulation through the heart. The procedure is, this method is popularly known as Hamilton's dye dilution method. The dye injected is usually Evans blue or indocyanine green. Before injection of the dye, 10 ml of peripheral venous blood is withdrawn and divided equally into two samples. In one sample of 5 ml, enough quantity of dye is injected to give a concentration of 0.5 milligrams per 100 ml. The other sample is used as a blank. 1 ml of dye solution containing 5 mg is injected rapidly in the basilic vein. From the limb artery, the blood samples are collected at an interval of 2 seconds in serial tubes. The tubes are then centrifuged together with the standard blank tubes, following which the concentration of the dye is determined photocolorimetrically. The concentration of successive sample is plotted in a semi-log paper. The resulting concentration of the dye in the arterial blood changes with the time. First, the concentration rises as the indicator carried by the fast moving blood reaches the arterial sampling point. Second reaches peak as the majority of the indicator substance arrives at the sampling point. This diagram showing the concentration of the dye against the time. It is gradually, the concentration of the dye is gradually going to increase, and at another point it starts again increasing because of the recirculation. Then the time required for one cycle is calculated by extrapolating the descending limb. That gives the time required for one cycle, and the area under this curve is utilized for the measurement of the average concentration of the dye in each circulation. Finally, the concentration falls as indicator carried by the slow moving blood arrives at that point. Thus, the result obtained gives a curve with an ascending limb, a peak, and a descending limb, but the descending limb ends with a rise. The slope of the descending limb is extrapolated to the abscissa. The point on the time scale at which it touches the abscissa gives the time of the first passage of the dye through the artery, that is T. The advantage of this method is it's an accurate method, and disadvantage is that it should not be repeated in short time as concentration of the dye in the earlier use may give errors. Then thermodilution method. Here the principle is same as that of indicator dilution technique. In this method, the cold saline is used as indicator. A double lumen catheter is used. Following catheterization, the cold saline is injected into the right atrium through the one side of the catheter. The thermistor is placed on the other end of the other side of the catheter. Change in the temperature of the blood is recorded in the pulmonary artery through the thermistor placed in the catheter. The change in the temperature is inversely proportional to the amount of blood flowing through the pulmonary artery. Advantages are saline is harmless, cold is dissipated, so recirculation is not a problem. It can be repeated many times if needed. Usually it is preferred for children as saline is non-toxic and useful in sick patients. And some of the disadvantages are the cardiac catheterization is required here also. Other methods like echocardiography. This is non-invasive technique in which the ultrasonic waves emitted from the transducer detects waves reflected from various parts of the heart. When it is combined with the Doppler technique, it determines the velocity and volume of the flow of blood through various cardiac walls. The principle is ultrasound waves are transmitted to the chest, and the reflection of these waves of the various parts of the heart is analyzed. The transducer, which is a small microphone-like device, is held against the chest. The transducer sends and receives ultrasound waves. By moving the transducer to various positions of the chest, different structures of the heart and the blood flow are analyzed. The computer software assembles the reflected ultrasound waves to create an image of heart. These images appear on a television screen. The parameters observed are size and shape of the heart, pumping efficacy of the heart, and wall abnormalities. So it is very advantageous as it is non-invasive and accurate diagnosis, and to develop a treatment plan is better here. It is safe and painless. Transthoracic echocardiography is used in critically ill patients as well. The major limitation is that it is often difficult to obtain good quality of image from the person who have broad chest uh, or they're obese or suffering from chronic lung disease. Ballistocardiography. In this method, vibrations generated by each heartbeat are received and converted into waveforms by transducer that records the cardiac activities on a ink recorder. From the recording, cardiac output is calculating using a special formula by analyzing the recorded waves. However, cardiac output measured by this method is not accurate one. X-ray method. In this method, radio-opaque dye is injected intravenously, and then the size of the heart is detected by serial X-rays in systole and diastole, from which the cardiac output is measured using computer program. Then pulse pressure method. So this is the difference between systolic and diastolic pressures, provides a rough idea about the cardiac output. So this is about the cardiac output and some of the methods of measuring cardiac output. Thank you.